translating yesterday night's circus night with the singers and the karaokes and so on and so on. They will probably come a little later today, but doesn't matter. So I'm not on the program, of course, but I couldn't resist to come and introduce my good friend Conrad, who is really over the past, I would say, almost 10 years and succeeded a few years ago, pushing for sepsis to be a patient safety issue recognized by WHO, and now it has been. So it was really, for us, very important. And as you probably know, today is the World Sepsis Day. So that's why we decided to celebrate together this World Sepsis Day, together with Conrad and a few other friends and colleagues, including Francesca, who is actually, you will understand, a mother who actually was faced through her life through a sepsis problem, as you will hear. And for a patient-included meeting, we thought it was really the way to go. So without further ado, I would like Conrad and colleagues to introduce the session. And I wish you a great session. As we used to say, don't think about sepsis only today because it's the World Sepsis Day, but at least it's good to be reminded about this very important problem that kills patients and make people and families suffer. Thank you very much, Conrad and Francesca. I'll let you introduce. Thank you.
So I'm very honored to be able to open this session. I'm not a professional in this field, even though I do have a scientific background. I was faced in my personal life with a very severe case, and I will try to wake you up for the human dimension, which, is often we are a very technocratic society, but actually with all the technology, it's still the human dimension which makes us fail, and it's sometimes good to hear the patient's perspective, which brings us back to the reality, actually. No conflicts of interest. So the classical citation, tell me and I forget, teach me and I may remember, involve me and I learn. So please don't be shy. If you have any questions, I would really like to involve you, and maybe it will waken up some instincts that in some case maybe will help you save patients later in your career. I came across this program from the WHO, and when I read their declaration, it immediately clicked with me. So this is the WHO declaration, which I really like because as patient, it really speaks to me. It's basically a world in which patients are treated as partners in efforts to prevent all avoidable harm in healthcare. PFPS calls for honesty, openness, and transparency, and aims to make the reduction of healthcare errors a basic human right that preserves life around the world. So for me is, what is the role of the patients? And I hope you all know the tale of the emperor's new clothes. There's this little guy there, here's all the healthcare professionals, and they think he has these new wonderful clothes, and there's this little guy who says, no, he's not wearing any clothes. The emperor is naked. So he's not held back by any peer pressure from his college. He's just telling you the reality the way it is. So back to the severe case, there's been a documentary on Swiss national TV, SRS, by this wonderful journalist, Isabelle Moncada. She's a superb medical journalist who put together this documentary. So if you have a chance, you can still watch it in the videotheque. So basically what happened, it was a course over just 5 days. Sunday night, she was feeling cranky. Monday morning, she woke up with really a hot fever, close to 40, so we immediately go to the pediatrician. Pediatrician doesn't find anything particular. He thinks it's laryngitis, so he just gives fever-lowering agents, which respond. So with these fever-lowering agents, she was still cranky, but the fever went down. Tuesday, strangely enough, she was quite stable. So she was responding still to this medication, and she was more or less okay. But by the night of Tuesday, it was worsening again. She was up to in the 40s again, and the night from Tuesday to Wednesday was kind of one of those nights, where she was waking up a lot. We gave her to drink electrolytes and tried to contain her. So Wednesday morning, she woke up really hot, and I said, okay, we have to go back to the pediatrician. So I just had time to drive our older daughter to school, and I immediately came back, and there I came home, and I didn't even have time to come in, that she was already throwing up all her bottle milk from the morning and started twinking on one eye. And I knew that was bad news. So I just took her, and we just drove immediately to the pediatrician again. I just remember opening the door and screaming for help. And there she starts this monster convulsion in front of our pediatrician. And he immediately understands, calls the ambulance. They managed to contain this with benzodiazepines. They immediately called the hospital, and within 10 minutes we're in the hospital. So up to then we had not lost 1 minute. Everything went well. And then something strange happened. We get to this hospital, and nobody takes care of us, even though we had been announced by phone. And so basically there, this nightmare starts, where we have these 20 hours in this hospital, and basically nothing major happens. So the next morning, on Thursday morning, she starts convulsing again, and she falls into a coma. And then there the doctors wake up, and they call the helicopter. Helicopter drive us to intensive care at the CHUV University Clinic, and then we get to the hospital with this ridiculous 2-minute helicopter ride. And there basically we have this bad news, that it's basically too late. So they tried craniectomy, they tried really the impossible, but Friday night she passed away. And so what happened during this, the absurdity, we arrived in ambulance, we left in helicopter, and what happened during these 20 hours? I mean, it seems just not believable. And other the fact that, she didn't really see doctors immediately. When we see, there were nurses, and there were crucial episodes, which I would like to go through. And these crucial episodes kind of, from a mother's point of view, where the doctor said, this is more or less normal, where I as a mother said, no, this is not normal, please do something. And there was the one first episode which immediately hit me, and she had this drop in temperature. There's this little daughter, 40 degrees in the morning, and then a couple of hours later she has this sharp drop. And so these are extracts from my journal, and I asked the nurse, what was her temperature. She didn't tell me anything. So she says, it's 35.5. This is good. The temperature came down. And I said, what? This is not good at all. I think she's hypothermic. She does not even have the energy to maintain her temperature. So that for me was like a natural instinct that it's not normal that it goes so low, the temperature. And then she's kind of, she's squirrely, and she said, actually, my thermometer does not work well for low temperatures. You have to add 0.5 degrees. And I request that the temperature is measured with an exact thermometer, and she replies, we do not have one. This is the only thermometer we have, and she lifts it up. So obviously she was hypothermic, but it was kind of dismissed, and such a ridiculous excuse. So what do you do as a patient? You go out in the pharmacy and buy new thermometers. What do you do as a patient in this situation? Then further on, like half an hour later, she starts vomiting all she had drunk at around noon, one huge projectile vomiting. And I call immediately the nurse. And I said, what's happening? She had this huge projectile vomiting, and she just tells me, she looks at this huge puddle, and she says, do not worry, this looks like a lot, but she actually retained quite a bit. And I said, how can she say that? So she calls the doctor anyways, and the doctor, same thing. It does not mean anything. Children vomit a lot. She could have drunk too fast. Her milk bottle, so makes her throw up, or she could have mucus. Mucus also sometimes, children choke and then they vomit, or because of the convulsion. As I told you, she had this huge convulsion, so she said it happens that children vomit after convulsion. And this, to me, was, again, in retrospective, just an absurd, a circular argumentation, You vomit because you have a convulsion, and you have a convulsion, obviously, because of intracranial pressure. That was the thing. I mean, and projectile vomiting, every professional, I'm sure, knows this is like the classical symptom of already some pressure building up in the brain. So it was a clear red flag indication. Third thing was the blood test. Around 2 p.m., I asked the nurse for the results. And instinctively and spontaneously, she tells me, rather indicative of a bacterial infection. And I say, what? I was, up to then, it was always, it's just feverish convulsion, viral, probably adenovirus, Coxsackie virus, something like that. Don't worry. And so she sees me, that I'm really worried because this was the first time I hear something about that it could be a bacterial infection. And she's uncomfortable. She knows she said something she should not have said. She transgressed her authority level. So she leaves the room and tells me she can't tell me more, but the doctor will explain me. And then obviously the doctor never came. And I am in this room, which was actually an isolation room, so I could not go out of this room. Neurologic status at 4 p.m. Finally, we had come to the hospital around 10, and at 4 p.m. she gets her first neurologic status. So I had Marisa on my arm, and the doctor asked me to sit down, Marisa. So Marisa, she doesn't manage to sit. She falls over to the sides or back. So instead of clicking, she tells me, like in this sort of, what I interpreted as quite mean, is your daughter retarded or something, does she not sit up at 11 months? And I tell her not only was she sitting very well, but she was ready to make her first steps. She could already stand quite well. But nothing is made of my input. And then in the medical file I later see, she was marked from the same doctor, somnolent, irritable, pale, and she had a hyperreaction to the patellar reflex, which is the issue of, the indication of something going on at CNS level. And actually what I also found is one of the neurologic symptoms in small children is the staring glare. And I had been noticing the staring glare like since Monday. Monday, she had this look on her face where I said, well, is she on drugs or something? She had this look which was altered. And had anybody asked me, of this typical symptom of meningitis in children, I immediately would have said, yes, she has this staring look which is not normal. And it's something which really strikes the mom when the look is altered. So finally, which was also really a huge red flag which was overseen, is about 8 p.m., the nurse and myself, we see that Marisa is breathing really hard, and she calls the doctor. But the doctor just orders a nose rinse, telling me that Marisa has a bit of rhinitis, so she has a little bit of clogged nose. And I pose without success. I tell them, it doesn't come from the nose. Her nose is clean. But the nurse tells me, she gives me, we are like a team, but she has to follow the medical order. So she goes ahead and tries to suck up the mucus with this hose that she stuck all the way down to her throat. Nothing comes up, the nose is clean. So despite the obvious proof that tachypnea was not due to the rhinitis because the nose was clean, no further exam was undertaken. And by the way, what I found out later, anyway, this rhinitis is absurd. Is never children with clogged nose, they don't get tachypnea like Marisa had. So to begin with, it was just an absurd excuse, an absurd argument. So if we look at the conclusions, which I could extract from the medical file and from all the retrospective things we had looked at and the research. So the nurses, they were talking about a bad general state. Marisa slept for long periods of time. She was irritable, pale, tachypnea measured hour by hour. She was monitored. They even noted a post-ictal hemifacial paralysis. They immediately said blood test is rather indicative of a bacterial infection. On the other hand, the doctors, and there were 4 doctors involved, there were 2 on duty and 2 interns. Good general state. Maria was playing in her bed, Glasgow 15, total recuperation of neurologic symptoms, even though they never asked me what the normal neurologic status would be. So the vomiting, pale, the fact that she was pale, the cries, the irritable status was put on the possible gastroenteritis. The somnolence, well, it was nap time in the afternoon, so it's okay, she was sleeping all the time. Tachypnea was due to the rhinitis. The tachycardia was the stress of hospitalization. Poor Marisa, she was stressed because she was in hospital. And then the leukocytosis, which was really the worst of all because they had really an objective blood test. She was at 23,000. So they said, yeah, well, when you convulse, sometimes there's leukocytes released from the bone marrow. So it's normal that there was leukocytosis. And the left shift, well, they saw a little bit of reddish in one eardrum. The eardrum, there was wax, but they could see across the wax, there was a little bit of red. So left shift also, there was an explanation for. So you see how every little symptom, every symptom is sliced, and at each time put into banalized somehow. And this is really, when you start slicing, instead of pulling together the symptoms, is just bad news. So some thoughts from my side. Active listening. It always comes down to it. Just don't pretend and look like you're listening. Really do listen. Professionals know their job. The family or the parents, they know their child or the patient. So it's really the professional job to bridge this link. And from really my point of view, the patient and the parent, they give these red flags to help finding the problem. And here comes the crucial point. If the information does not seem logic, and sometimes, you have to think hard, you have to dig deep, but this is a reason to investigate more and not to disqualify the parent or the patient. This is really, in my opinion, this is really the crucial issue here. And really this question that haunted me is what should or could I have done to be heard? I really felt like, should I have punched? I'd rather be myself, incriminated for physical violence and Marisa alive than having to be undergone. The neurologic status of Marisa was not normal. And, there's also this asymmetry of forces in a hospital setting. So patients don't speak out easily always, So it's really, this active listening is really important. And why is it so important? Because, even, oops, sorry, I'm going the wrong direction. Even, as doctors, as humans, there is this error of reasoning that is ingrained in our brain. And I came around this article from Der Spiegel, it's a German from 2011, which immediately spoke to me. And it was really, I said, yeah, this is exactly what I felt. It's like the error of reasoning is, first of all, accumulation of cases. You've seen 10 gastroenteritis, the patient comes, the 11th case, obviously there's a tendency to think it's again a gastroenteritis. And this goes hand in hand with the probability of the symptoms. You have a convulsion. Well, yes, 70% of the convulsions are due to a viral infection, but then there is the 30%, which is bacteria. So first you exclude this 30%, and you don't immediately go for the 70% where, the probability is harmless of a more easy disease, you know. Then there's a psychiatrization of symptoms, you know, stress. Tachycardia is due to the stress of hospitalization. This wishful thinking is also, in French, we have this word, la pensée magique. You know, somehow magically this will resolve, because we live in a society of a lot of technology. We have all sorts of means, you know. We are sort of overconfident. This is the next point, you know. But with all the technology, it's important to remember we cannot buy back time. We cannot buy back time. We have to be always reactive. We cannot lean back with all the technology we have and think that will resolve the problem. We have to be always alert and proactive. Then the sunk cost, everybody knows this, you know, the further down you've gone one path, the more hard it is to come back, you know. And selective appreciation, I think we also all know that as the tunnel vision, you know. Once we've gone this road, we don't even see anything that could dismiss our hypothesis. We just take in the facts that confirm our hypothesis. So here comes again the little man, you know, but he's not wearing any clothes, you know. We as patients, we see these things sometimes. We're not conditioned by all these daily situations in our hospital that bias our mind and our appreciation. So this is really always listen to this little man saying the things the way he sees them. And what we all want to know is truth above all, you know. I mean, this is during and after taking care of the patient. And during, I mean, if I tell you that for me, really what I discovered when I got Marisa's medical file was the diagnosis, which, you know, probably viral, with adenovirus and Coxsackie virus that was mentioned. But then there was this big highlight, meningitis, with like this big red triangle attention, and this note, it may be also meningitis, so please be careful. So from the first moment, they had eyed at meningitis, and they had never told us. They told us only about this viral infection. Had they told us that that meningitis was part of the differential diagnosis, I mean, immediately we would have said, do a lumbar puncture, antibiotics immediately, but they didn't even give us the option, you know. It was something they wanted to keep to themselves because we don't want them to worry, you don't want to worry, everything, this wishful thinking idea, right? It will all be fine. So as doctor, really, you have to expose your vulnerability, and it is really the underlying prerequisite for trust, and it's really the final demonstration of integrity and professional behavior. It's only through truth that, you know, a patient can really help you also. Yeah, the day after, what did we do afterwards? You know, to be sorry was not enough. We wanted to see, especially I wanted to see change. So immediately, the day after, I started working on this foundation. And it was, for once, a foundation because the doctors at the university clinic that took part in our trauma these last 2 days of her life, and we saw with such, you know, little means they were compared to adult or geriatric medicine. So we started this pediatric research fund, and it's running up really well. We do really very applied science, life-saving science, very applied in nutritional support of critically ill children. I'm proud to mention that we won the Pfizer Research Prize. We won the Pfizer Research Prize 2018 for this study. Protective ventilation and other equipment, which is obviously important when you're dealing with children whose life hang on a thread. Infectious diseases, we did studies on adapting antibiotic resistance, on finding premature markers other than CRP. cardiovascular diseases, blood coagulation. We have now quite a list of good publications here throughout the medical community. The other thing that was more my job is really digging deeper and having contact with the Ministry of Health, because I thought, the way this happened, this is not normal. There is for sure a systematic error or something. So they set up a zero refusal politics. So one thing is, before the helicopter, this is one thing I discovered afterwards, we waited 4 hours to get a bed somewhere in intensive care. And the year Marisa died, there were like 80 refusals in this country of children in critical not finding a bed in intensive care. So we immediately got 8 beds more in intensive care. We set up, or actually the Ministry of Health set up a triage program for pediatric emergency nurses. This is also a problem. You go to your pediatric doctor, he has maybe 20 years of experience, then you go to the emergency and you find an intern for this more difficult situation. It's totally absurd. So now there's this triage program, so there are nurses who know how to do pediatric emergency triage, and also the presence of a senior doctor at emergency sites, which was up to now not possible, and also transparency policy on undesirable events, so this is also something, we have to learn from these events. We cannot just shrug them under the carpet. Then education, this is also myself, I'm involved, and these are seminars I do with the nursing school here in the region, first to second year bachelor, so it's on patient safety as well as what we call habilité clinique, so clinical appreciation. And these, the students love these, because it's something they can relate on. Sometimes they have already done an internship and they already see some of these things. So it's also a platform for them to open up and discuss the things they have seen. And next year we're going to launch the first interdisciplinary, also involving med school, so doctors and nurses together, working together, because this communication is really hard. And as you see in this order, the medical order, that the nurse has to do something where she's actually the one close to the patient and the medical doctors may be further away. So this communication really is also critical. And then once in a while, I work with WHO, this patient for patient, sporadically whenever an opportunity comes along. So I would like to thank you for your attention. If you want to link in, we have a Facebook, we have a crowdfunding platform in case you want to help us. You can organize events, fundraising events, or direct donation. And if you want to know about the foundation, this is the link. Thank you.
Thank you so much. So I think it was so moving for everybody. And on the other hand, it's so encouraging that, like some others around the globe, didn't accept this bad healthcare. And you are a shining example, like the Roddy Staunton family, like Carl Flatley, who founded the Sepsis Alliance in US because he lost his 22-year-old daughter after an hemorrhagectomy, etc., etc. And I think it's also encouraging for us as a global sepsis alliance, and I'm sure also for WHO, that it was the right thing to bring this on a other level, and I think we should move jointly along this way. Thank you so much. Yeah, as I said, it's not so easy to talk after such an important but also very emotional talk. So what I would like to point out is where we come from, because this is not a single case. It happens hundreds of times a day around the globe.
if not even more. And this is what I would like to talk about, what helped us to make progress, the opportunities and challenges that indeed came with the WHO solution, and what we need to go for the next level. When I started as a young resident in an ICU in the late 70s, I realized that sepsis was the #1 cause of death already at this time on our ICUs. But I had never heard the word sepsis during my medical education. There were no clinical practice guidelines, no data on the epidemiology, no teaching about sepsis, no knowledge on the sequelae, because sepsis is not over if you survive, but I will talk a bit on this. And there was no way in terms of advocacy or lobby, and not speaking about funding. And ironically, that this topic was further moved on in one part by intensivists like myself, but also some others, still a minority around the globe, because they felt and saw what happens. But there was the first money to increase awareness came from industry, who understood they cannot sell a compound like anti-TNF to modulate the immune response, which was a great hope. They did surveys in several countries, and what you see at this time in 2003, in most of the countries, less of 10% of lay people had ever heard the word sepsis, and this is even more true for policymakers, etc., etc. And even when we launched the first World Sepsis Day in 2012 and launched the World Sepsis Declaration, sepsis was only on the website of WHO for neonatal sepsis. It was not, the word sepsis not appeared on any A to Z list of any centers of disease control. Sepsis was also only presented in the Global Burden of Disease report as neonatal sepsis, although lower respiratory tract infections have been ranked as #1 cause of quality of years life lost. So, and of course, as I said, poor knowledge of lay people and sepsis also poorly represented in the media. What helped us to make progress? We had to learn from other high-profile fields who started already in the 40s and 50s of the last century to understand that a disease needed to transform politically before it could be transformed scientifically. They had ad in the New York Times, Mr. Nixon's, you can cure sepsis. They asked for a moonshot for sepsis and a Manhattan for cancer, and a Manhattan project for cancer. And they were successful. It took decades, but we have made progress. And the HIV story is an excellent story. What can be done within 30 years if all standing together and investing and moving back and so forth. So what was important to make progress, that we, for the first time, had data. And when we did this first survey and published it in 2016, we found there were only data in a few high-income countries. And by extrapolating this data, we came up with 30 million cases and between 5 and 8 million deaths. However, as we all know, and this is long time accepted, the deaths from infectious diseases, which by definition are deaths from sepsis, are much higher in these other areas of the world. And even in the high-income countries, sepsis is extremely underestimated. This came out only recently because we learned, although there was a debate also, and we were addressed as Global Sepsis Line, I personally, you are overselling. And there was a big debate in the US whether these increases of sepsis numbers are real or not. And that's why CDC funded a study with 400 hospitals who have electronic health records. And what we found, that 5.9% of all admissions were due to sepsis defined as along the new sepsis definitions. And only 2.5% of these patients, less than half, were documented in the ICD classification system. And if you look at these figures, that came up 1.6 million cases and 260,000 deaths in the US. So this is much. This made Bloomberg now to understand that sepsis that the US faces a 27 billion sepsis crisis. It's the #1 cost driver. And it was already 10 years ago. And there was no awareness at all on this. And it's also true for Sweden. They are lucky because they have databases in which they document every patient who received antimicrobials for longer than 3 or 4 days. And they went into this database and they looked how many of these patients were treated with antimicrobials, had fulfilled the criteria for sepsis. And they came up with an incidence of 687 per 100,000 inhabitants, and only also there 50% were coded in the I2C coding system. If you assume that the number of sepsis cases in Sweden are similar to the rest of Europe, you come up with these numbers, more than 3 million and more than 600,000 annual deaths. And it's not on the agenda. What was also important to move forward and to get to this solution, to foster the understanding that sepsis is a primary cause of deaths from most infections, and that it has been addressed as an emergency because it's amenable when you treat it first and timely, and every hour counts. What was so crucial was the support by family members and by sepsis survivors who stood up and made this case. And worldwide, in the meanwhile, they are no longer accepting this poor quality. This is the Rory Staunton family, this is the Carl Flatty family, this is the UK Sepsis Trust. And due to their work, in the UK, in the US, for example, CDC took up this issue. And when they first put in sepsis on their ABC list, they listed it under healthcare-associated infections. And this family ran crazy because their child had hurt himself with 12 years by basketball. And they understood this is not healthcare-associated. So if the CDC at this time, and this is true for WHO and was true for WHO and for most Ministry of Health and CDCs, they thought only in terms of prevention of healthcare-associated infection. It's crucial, it's very, very important. But you must not miss and understand what both in US and UK is clear now. 70 to 80% of patients come with sepsis into the hospital and are poorly recognized, etc., etc. But they acted in the US. They worked in difference to others. So it was important to have guidelines, and this happened in 2000. I think it was even more important to demonstrate that quality improvement initiatives can tremendously reduce sepsis mortality, increasing awareness, educating nurses and other healthcare workers. And finally, I think it helped that we had organized this World Sepsis Day movement and had successful World Sepsis Days and also a World Sepsis Congress, etc., etc. And in the meanwhile, we have also very good data that mandated sepsis regulations, which were initiated for example, in the state of New York, are also related of better outcome. What was also important, to reach out to policymakers, and without this person here, who is now the Chancellor Minister of Angela Merkel, Helge Braun, we would not have been able to convince our Minister of Health to try jointly with other German-speaking ministers of health to promote this sepsis resolution. And over time, we got support and got into the mindset of these other people that you see on this list. So, and this resolution comes with a lot of opportunities. And most importantly is that it fostered the understanding that sepsis is not only a bacterial issue, but that it may be caused by all types of microorganisms, virus, parasites, and also, and of course, to foster the understanding that most common infections like pneumonia, urinary tract infections, abdominal infections cause sepsis, because the understanding by media and sepsis is a problem, first of all, of unclean care in the hospitals, and it's a problem of so-called superbugs. And to tell you, still 98% of all patients with sepsis are responsive to the antimicrobials we have. But the problem is that they don't get them in the right time. So that's what I said already, to overcome these notions and misconceptions was also helpful by the resolution, as was the statement that it's a time-critical disease like myocardial infarction. Everybody knows that stroke and myocardial infarction are emergency, but it's not the case for sepsis. And and this is crucial also in this resolution, it urges the member states to come up with national strategies to fight sepsis, to improve prevention and diagnosis and treatment, and also long-term care for patients with sequelae. And they understood and urged also to support, to increase awareness, because it's an awareness issue and then, of course, an education issue that both lay people understand. And they often understand better than healthcare professionals that is something wrong with their loved ones. You understood it, and it was clear to you, and it often also in the hospitals, on regular wards, patients, family members understand after surgery there's something wrong, but it's not taken up by the nurses because they are not adequately educated on this. And it's great that also WHO supports World Sepsis Day. And it's very important too that the new Director General made the point that it's and called it a tragedy that most of the at least 600 million sepsis cases, among them more than or at least a million babies, are preventable. Preventable by vaccination, prevention of infection, by clean care, early recognition, and appropriate diagnosis and sepsis. And that's why I'm so pleased, I think, that you, most of you come from the infection prevention field, that we have the same goal and we must come much closer together, because this is not an we cannot, this is what I learned as a intensivist, we cannot save patient safety. We save some. Yeah, but we can, the problems are in terms of prevention and early recognition. And that's why sepsis, and we are on the way of it, needs to become part of all these great programs, be it the Sustainable Development Goal. If we want to achieve them, it must be understood that it's essential that it's much more combined as it is now with the big campaigns, highly staffed and financed campaigns against AMR. It has now become part of patient safety and also other global action plans. And it's in there, and there's also a slide from WHO. They understood now. It's about maternal health, it's about health of newborns and children above years, it's about malaria, tuberculosis, etc. And it's about achieving universal health coverage. And it was great that an Assistant Director General by this meeting that was convened by Benedetta Allegranzi, who's luckily also in this room, 1 year after the adoption of the resolution, where we discussed how can we foster the enactment of this resolution around the globe, who said sepsis is a key performance indicator for the quality of any healthcare system. And this is so true. And why are we not there? Because our healthcare system is working in silos. So the cardiologists think about cardiology, the nephrologists, etc., etc., the neurologists for this and that. There's nobody in our healthcare system on all levels, and especially in the hospitals, who care about a disease which happens in all disciplines and emergency medicine and everywhere. And if you want to make a difference, you have to sit together from all these departments and to have a common strategy and plan. And we were lucky that the person I told you, this Chancellor Minister Helge Braun, why? He's an intensivist. He knew what sepsis means because he has studied sepsis. And that's why he supported us and also said you need to ask for a national sepsis plan. The same is true from our last commissioner in the EU. He told me, I know what sepsis is when he addressed him. I was for 14 years a cardiac surgeon in Lithuania. 4 weeks later, we had a meeting with him in Brussels, and he supported us with the launch of a European Sepsis Alliance because he understood that sepsis is the #1 cause of death and disability in Europe. And he said, it's time to act now. And he calls all member states in Europe to do also something to improve the quality of life of the sepsis patients. And one result of this is that jointly we achieved it to get sepsis in this resolution, which ironically was adopted by the European Parliament on September 13th, World Sepsis Day last year, where 3 times the relationship and the connection between AMR and sepsis was understood. And Sir Lion Donaldson has understood it very well, what it meant that we achieved this resolution, because he said some very important clinical issues, some of them affecting life and death, stay largely in a backwater which is inhabited by academics and professionals, and enthusiasts dealt with very well. And to the enthusiasts, I would also count people, mothers and family members like you. But what he also said, rightly, it's a public space where sepsis needs to be in order to change things. And this is so true, and this is the next step if we want to make a difference. And this is what you have done on an individual basis, talking to the ministers of health, because it is still very far for this. And we need to overcome the differences in sepsis outcomes. And if you look at this, you see that there are countries like Australia who and they have one of the best healthcare systems in the world, as you see, and their mortality decreased and halved over the last 10, 15 years. And yet, today, I got a tweet by my friend Simon Finther, that the Minister of Health there tweeted today on World Sepsis Day that it's a pity that only 20% of Australians know what sepsis is. So they are working, and we are just in a minute what is different in these kind of countries. If I look on Germany, who has the most ICU beds in the world, who are spending 40% more on healthcare than the average European country. Why are we so bad? Because it's left, the quality of healthcare in Germany is left to the discretion of the single physicians and the head of departments, and this is a problem that has to be overcome. So Germany is closer to Brazil and Turkey, and we need to change this. This is a slide of Markus Friedrich, who was the chief medical director of the campaign in New York to implement this regulation. And one reason, beside Rory Staunton, was that the Governor Cuomo said, it's not acceptable if you go on a hospital on the right side here of this slide, your likelihood to die is twice as high as if you go to a hospital on the left side. And they understand that is not to explain, that this is related to the quality of care, and want to overcome this. And if you look on the list, what is the difference between countries with high quality, with low sepsis and decreasing mortality? They have a high standards for quality improvement. They have programs for infection prevention and control. And especially, they educate their healthcare workers systematically in detecting a deteriorating patients. In UK and in the Anglo-Saxonian countries, every nurse and healthcare workers are taught when they enter the system, when they enter the hospital, in what is called the early warning score. In UK, it's called the National Early Warning Score, because in the context of the sepsis campaign, they have updated it, etc., etc. This doesn't, and they have rapid response teams. In Europe, we have reanimation teams. I am an anesthesiologist. We are called when there's a cardiac arrest. It's crazy. And it's hard to implement. And I was told by my surgeon, if a patient is deteriorating on his ward, first a surgeon has to be seen before somebody else comes. So this is a kind of thinking which is feudalistic, which is back to the Sauerbruch times, and this needs to be overcome, and some of the countries have overcome. And actually, this is a slide from the Clinical Excellence Commission in New South Wales, Australia. And they have, in Australia, implemented in 2017 rapid response systems, meaning having teams and education. And they understood you must intervene not when you need advanced life support.
This is a manuscript that was published in the New England
and
Journal
this is
just this week. And
this tells you also what was the outcome, and this has been published in the New England Journal, what were the outcomes of the quality improvement campaign in New York. You see that any delay of administrating antimicrobials increases the increases the survival decreases the survival chance by 1 to 2% per hour. And overall mortality rate by this campaign over 18 months decreased by 5% absolute. And what happened in the children aged 0 to 17 years, those in whom the bundles which were mandatory to fill, and bundles mean take a blood culture before you give an antimicrobial within the first 1 hour or 3 hours at least, and do a lactate. In these kids where these bundles were fulfilled, sepsis mortality decreased to 7.5%, whereas where these bundles, these quality measures were not done, were 13.2%. Then I asked myself, what is the mortality of this great age group in Germany? Because we can analyze the data that are reported by every German hospitals. You see, we have a mortality rate of 17.2%. And we are talking about more than 1,000 children in this case. So what we could achieve in terms of reduction of mortality. Look, and this is data from the UK Sepsis Trust. They were, by their great campaigns, able to increase over the last years the numbers of patients who were diagnosed in the first hour from the range between 30% up to 80% and received their antimicrobials in due time, and this went along with a dramatic reduction of mortality. They have public, at their bus stops, you are educated with the question, just ask, could you sepsis? In Germany, when you go to bus stops, you are educated, which is not wrong, on sexual transmitted diseases. In UK, every family who gets a child gets a booklet with the symptoms of neonates and children, and they have a 24/7 number that they can call. So, and this is this is the way to go, that sepsis must become a household word. This we had when we launched our sepsis declaration. And it's great to see that in the meanwhile, quite a number of countries, and including Saudi Arabia and Sudan, they have national sepsis programs. In Germany, we are still fighting for it, but at least we have some activities. Although only 5% of the hospitals joined our German sepsis quality improvement concept, and only 50% of this hospital take part in the Clean Care, Safer Care or hand wash campaign. It's great that now in the patient safety resolution of WHO, healthcare associated infections and sepsis are mentioned as problems, and we make progress in this respect. And I mentioned this, and we must come into these programs. And definitely, this gentleman was wrong, who in and this is a Surgeon General of the US, who said that the book of infectious diseases can be closed. So you see how poor in that time, and I think with this I finish. In that time, one really believed by better vaccination, by clean care, sanitation, etc., the crude mortality rate in the US fell dramatically. But this was, first of all, a perception, not a global perception, but a US-focused perception, and you have seen the data that's even not true for the country. So what we need in the future is to really, what I said in the beginning, to work jointly, to have infection management plans, to come out from the silo, to combine infection prevention control with AMR and with sepsis. And with this, I am at the end, and thank you for your kind attention, and would like to encourage you to join the fight and to share our vision for a world free of sepsis. Thank you so much. We will do discussion at the end, and it's now my great pleasure to invite Janet Diaz, who has helped a lot to get to this resolution, and now is working even more so for WHO, and it's a pleasure to have you and to present you the perspective on.
Thank you, Conrad. So, good morning. I would like to thank the organizers of the conference for giving us this opportunity to discuss about the WHO perspective, improving prevention, diagnosis, and clinical management of sepsis. And I speak, my current role at the WHO is as the clinical lead for health emergencies in the Health Emergencies Program, but I'm speaking now on behalf of the entire WHO Sepsis Coordination Group, so that's my pleasure. As already discussed, the WHO Sepsis Initiative was launched in May 2017 at the 70th World Health Assembly, where the member states of the WHO adopted the resolution. And simply, it is to improve the prevention, diagnosis, and treatment of sepsis. And we all knew at that time, as Conrad has also alluded to, we need to better understand sepsis epidemiology and the burden of disease. You've seen this slide already. This is to show that this work is in line with the Sustainable Development Goals, clearly to reduce the global maternal mortality, to end preventable deaths of newborns and young children, to end the epidemics of infectious diseases such as AIDS, tuberculosis, malaria, waterborne diseases, as well as other communicable diseases, and to achieve universal health care, which means access to quality, essential healthcare services and vaccines for all. And I think from what we heard in the first lecture, quality healthcare services is what was highlighted with the patient perspective and patient safety. The WHO Sepsis Coordination Group is composed of 9 different teams, ranging from multiple departments, and we're all working together to have, one cohesive approach to sepsis. Currently, Professor Allegranzi, she's no longer, I think, in the room, but she is our coordinator at the headquarters office here in Geneva. She sits in the Infection Prevention and Control and Service Delivery and Safety Unit. But my other colleagues work across the board in maternal, newborn, child, and adolescent health, essential medicines and health products, information, evidence, and research, infectious hazard management, the health emergency program, that's where I work, antimicrobial resistance, reproductive health and research, immunizations, vaccines, innovation, access and use, and environmental and social determinants of health. You've seen this photo as well. To unite and to bring together the stakeholders, global stakeholders in sepsis, experts in different aspects of sepsis care, WHO convened a technical meeting in January 2018. You can see the website for a complete report of that meeting. But simply it was looking at, and complexly it was looking at the priority and actions that need to be taken to reduce sepsis, to eliminate sepsis, and we bundle those into the various different types of actions to do awareness-raising activities, to create reports that can be used to impact policy-making decisions at high levels, to develop evidence-based guidelines, to work with countries on implementation strategies, to develop education and training activities, to do research where there are gaps, and of course the usual role of the WHO in networking, coordinating partner actions. So in the next few slides, I do want to highlight what our colleagues in the WHO, alongside the partnerships with many stakeholders around the world, have been doing over the past couple of years, and highlight some of the most important pieces of work and advancements. So for example, the World Sepsis Congress on maternal and neonatal sepsis was co-hosted between the WHO and the Global Sepsis Alliance in September of 2017. To build on the hand hygiene campaign, in May 2018, the hand hygiene campaign expanded it to mention the word sepsis. So here, it's in your hands, prevent sepsis in healthcare, and that was the focus. Alongside of that, there was other informational products that were developed, or infographics, and these are quite nice and available on the website, but how to prevent sepsis, giving very simple messages about the epidemiology of sepsis, who is at risk for sepsis, such as pregnant women, children, those that are immunosuppressed, and how can we prevent sepsis, both in the community as well as in the healthcare centers, in the community with good hand hygiene, with good sanitation facilities, and in the healthcare settings by applying infection prevention and control interventions and standard precautions, as you all are very familiar with. And finally, in the bottom column, how about if you do develop sepsis? What improves your outcome? Early recognition and appropriate treatment. And you've heard that message already. On the right, there is an animation video that's also available on the website. To move on to my colleagues in maternal sepsis, the Global Maternal Sepsis Study is also called as GLOSS, is ongoing, and the purpose of this study is to assess the burden and the current management of maternal sepsis in health facilities across different settings. So this is a 1-week inception cohort study that ended in 2017 of all eligible pregnant or recently pregnant women admitted or hospitalized in participating facilities. In total, 53 countries were enrolled, 2,850 women recruited. Most were from lower middle income countries, and this included 713 health facilities. So this is quite a piece of work that I commend my colleagues on. And the results show, not yet published, 70 per 1,000 live births suspected or confirmed in hospital maternal infections, and that infection was underlying or a contributing cause of half of the maternal deaths. The GLOS group also is working on evaluating pre and post an awareness campaign, so to see how awareness campaigns can impact healthcare providers' knowledge of maternal sepsis and identification of its current management, and also their perception of confidence in making correct diagnosis. So this is also very, very important work to see, do our campaigns, how does that actually impact provider practice? And also want to highlight their a website that I think is a very, very nice website. So the srhr.org/sepsis website, which gives a lot of materials about the GLOS study, how to become, involved in that research, and as well as many tools on maternal sepsis, such as infographics and other simple information that can be used at your hospital. Also ongoing is a maternal mortality and morbidity study. The background here is infection is, of course, an important preventable cause of maternal mortality and morbidity, but remains one major cause without a systematic literature review of the incidence. So the purpose of this study is to describe the incidence of maternal peripartum infection, and colleagues are doing a systematic literature review and meta-analysis. And preliminary results have shown that over 31,000 relevant articles were found. 111 studies included from 46 countries were included, and noting that there was very little data from developing countries, and marked heterogeneity in study designs and infection definitions, as you would guess. So the results, again, these are submitted for publication, I think are helpful, but also let us know how much more work we have to do. So there's differences in definitions, limit comparability of global estimates, and the recommendation is better quality research using standard definitions of sepsis is required to improve comparability between study settings and to demonstrate the influence of risk factors and protective interventions. So although we do have a sepsis 3 definition, which Conrad already told us about in his lecture, the applicability of this definition in all different settings for different populations is not clearly being implemented. So that's limiting our ability to integrate different research studies to paint a full picture. I refer you to Dr. Doris Chu if you have any additional questions about this. To move on to laboratory testing, diagnostics. Currently, there are 2 target product profiles for antibacterial resistance that are now on the WHO website for 1 month for public consultation, so I refer you to those. In March 2019, a technical consultation on in vitro diagnostics for AMR took place here in Geneva. They drafted a landscape of diagnostics against antibacterial resistance with a list of gaps and priorities, and then developed target product profiles as identified from this meeting. To move on to the GLASS group, Global Antimicrobial Resistance and Antimicrobial Use Surveillance System. So this is an ongoing study. It includes collection of data from patients with bloodstream infections on antimicrobial resistance, looking at the following pathogens such as E. coli, Klebsiella pneumonia, Acinetobacter, Staph aureus, streptococcal pneumonia, and Salmonella species. And thus far, it has collected, has 83 countries enrolled in one area as of September 2019. I also give you some information from our very early systematic review on the epidemiology of hospital-acquired sepsis. So this is coming from our infection prevention and control colleagues. And these are very preliminary results, not for dissemination. But as you can see, 74 studies were selected, and they're very heterogeneous, which is a common word here. 24 hospital studies, 6 population-based studies, 44 ICU-based studies. So very heterogeneous patient population settings and outcomes, thus will limit the analysis, and noted low and very low quality studies, and most from high-income countries. And here, the preliminary conclusions, differences are in definitions limit the comparability, so that I've said that before and I repeat. And more evidence is needed to standardize definitions to improve the comparability and to estimate the impact of IPC. And you see here the analysis was looked at by region, trying to look at different regions and what was the, how much healthcare-associated infection sepsis per patient population. And there you can see some of the numbers that were found. My focus of work is actually on clinical management in the emergency program. So we work mostly with emerging infectious diseases, but also working on the, moving forward, the sepsis clinical management guidelines on for the WHO. So our task is to develop clinical case definitions that can be used in all resource settings. I think with the sepsis 3 definition, we know that is clear, but how can that actually be applied to a clinical setting, a primary care setting, in a district hospital, perhaps in Africa, that has limited personnel, limited staff, maybe limited equipment, but what are the essential ways to start to recognize early a patient with sepsis in all settings? So that's important. And then go on with clinical management of the patient, again, from the onset that they arrive to the healthcare setting, wherever that may be, primary care, hospital, through their hospital stay, you know, and for some patients that will be intensive care. And I give you my perspective. Actually, I'm an ICU doctor, so I have the experience of Conrad working in ICU and seeing patients come late and seeing patients with septic shock and trying to do advanced life care support to save lives, knowing that if we just caught them earlier, we would have had a different outcome. So how can, so this is an important part of the clinical management guidance that the WHO wants to support in development, of course, including adults and pediatric patients, and then again, making it applicable to all resource levels. So we're starting right now doing a systematic review of all available current guidance on sepsis management. And everyone is, well, I assume most people are very well aware of the Surviving Sepsis Campaign guidelines. You know, those were just, you know, recently published, I guess 2016. And the pediatric guidelines are currently underway, and they're doing revisions to the Surviving Sepsis Campaign, which I imagine may be published within another year or so. So the WHO doesn't want to duplicate the work of, you know, many international colleagues that have been working very hard around the world on these Surviving Sepsis Campaign guidelines. But what we would like to do is to ensure that, you know, that the quality processes were in place to make a transparent and valid guideline, which I do believe the current Surviving Sepsis Campaign has worked hard to ensure that. But also find the gaps. What are the gaps in that guideline that are needed to be addressed with a WHO guideline? What is missing to make sure that all the providers that may encounter a patient with sepsis have enough information and recommendations on how to proceed? And so that will be our approach on moving forward the sepsis guidelines, and we hope to have that review done by the end of the year. I do want to say some successes we have had this year from the clinical side, although the outbreak is ongoing and that is complicating us, our work in the Democratic Republic of Congo. So we have looked, as Conrad has mentioned, sepsis. We think about bacteria, but there's also other causes of sepsis, and Ebola virus disease at its most severe form, complicated form, is an infection that causes multi-organ failure and death. So in this Ebola outbreak, we have used early diagnostics, mobile diagnostics to make earlier diagnosis in the field, and the use of GeneXpert for rapid diagnosis has been essential in that. We also use point-of-care testing by biochemistry testing, including CRP and other white cell indicators to help guide us with treatment. We've published on the web and also implemented as part of the standard treatment in Ebola treatment units, optimized supportive care for Ebola virus disease, and this really focuses on doing good supportive care for these very sick patients with sepsis and multi-organ dysfunction and failure, including treatment with IV fluids for shock, correction of electrolyte abnormalities, and glucose therapy, and giving actually antimicrobials for a possible co-infection with a de-escalation approach. And in addition, we've worked on establishing safe, biosecure Ebola treatment units that are more patient-friendly, provider-friendly, to help us do this type of more intensive care, even in the remote, difficult conflict areas of the DRC. On this picture, I just show you our guideline as well as a biosecure cube that is used in 2 Ebola treatment units, which is a single isolation independent room with the person's, the healthcare providers inside in full PPE with the patient, and then you can be outside discussing things with the provider to ensure the care is good, and also give things and do monitoring from the outside through safe introduction of various wires through this cube. So there's a lot of innovation happening in isolation and treatment designs in the DRC now. And then just to talk about therapeutics in Ebola virus disease, we speak a lot about antibacterials, but antivirals, and the use of other specific pathogen-directed diseases to improve mortality and reduce death. So under the WHO coordination, the National Research Institute of the DRC, INRB, and the NIH sponsored the PALM RCT trial. Together Saves Lives in Swahili is what PALM means. And the preliminary analysis has found that treatment with 2 monoclonal antibodies named monoclonal antibody 114 and Regeneron EB3 in combination with the optimized supportive care is associated with improved survival when compared to ZMapp, which was the standard of care arm. And this has been submitted for publication. In addition, the WHO and the INRB sponsored the MURI framework for the use of investigational products under ethical and regulatory approval since the beginning of this outbreak. And that has allowed hundreds of patients with Ebola virus disease to have access to an investigational product under good ethical informed consent and monitoring. And I link you to the website so that you can read the results of the preliminary analysis. Finally, the Global Sepsis Report. This is to be issued in May 2020. And this will be a collaborative effort between the WHO Sepsis Collaborative Group, and the current outline is as follows: background on the resolution and the overview of sepsis as a global health problem, discuss the primary research on sepsis epidemiology. I've already discussed the GLOSS study and the GLASS study, and then the maternal death study, but there's also an abortion-related morbidity study and the African neonatal sepsis trial, which will be included. To provide systematic reviews on sepsis epidemiology and global burden of disease. So this will continue on the healthcare-associated sepsis that I also discussed, but also on newer work to update the sepsis in adult population and neonatal sepsis and maternal sepsis work. This report will also work on methodologies and challenges limiting sepsis epidemiology and research, and of course focusing on the sepsis definition, which we've already been discussing, methodologies for doing research, other approaches for detection and diagnosis, and start to develop the roadmap for future sepsis work, research gaps, and the agenda for sepsis. So with that, I want to acknowledge my colleagues who contributed to this slide set. I am speaking on their behalf as the WHO Sepsis Coordination Group, specifically Professor Benedetta Allegranzi, who's here in the front row, for being our lead coordinator at WHO, Alessandro Cassini, Mercedes Bonis-Ximenes, Doris Chu, Francis Musi, and Sergi Ehrman for contributing their slides, as well as to all the partners that are doing this work with us. So thank you for your attention.
Thank you, Jeanette. This, I think, is very encouraging to see which progress has been made over the last 2 years. I was somewhat skeptical after the first year, but now I think we are scaling up, and it's great to see. And for the sake of time, I think we should move forward to another very important issue, because as it's true, sepsis is the #1 cause of death in under 5-year-olds, and we are pleased to see that Julia Bielicki from UK, basically being from Germany, is presenting her talk on this issue.
Sorry. Yes, so thank you very much for giving us the opportunity to speak as well. My name is Julia. I am a pediatrician and infectious diseases expert, and I work in London and in Basel here in Switzerland. And I'm actually speaking on behalf of the Global Antibiotic Research and Development Partnership, GARDP, which some of you in the room might have heard about, who's working very intensively on neonatal sepsis. And the only other thing to disclose is that my husband works for the enemy. He is a lawyer at Novartis, but I assure you that that has absolutely no bearing on what I'm going to talk about today. So if we just look at GARDP's research and development operations, first of all, you can see that this is a sort of classic development of pharmacological assets structure, really in the area of antibiotics. As you know, the antibiotic pipeline is very slim, and there are all sorts of problems translating some of the assets that do get developed into clinical practice and implement them in day-to-day clinical care. And GARDP really tries to span this whole process and has so far selected to focus on 4 areas, and you can see that neonatal sepsis is one of them. And you can ask yourself, why is that? So these are neonates. In fact, these are my 2 sons. They're no longer neonates now. One of them's now 3.5, and the other one is nearly 1 year old. But you can immediately, when you see those pictures, see that you get a reaction where you say, you want to protect these babies. And that's a very natural instinct, because in fact they are highly vulnerable. All of us, when we were babies, neonates, we were highly vulnerable to all sorts of insults, and in fact also very highly vulnerable to severe infections. And this is something that is very acutely seen if you look at the Sustainable Development Goals. Sustainable Development Goal 3 has already been mentioned, where we're wanting to set new targets or reach new targets in terms of neonatal mortality. And in fact, neonatal mortality is still something that remains under address. So you can see here recent data about the progress we have made so far, and you can see that in fact from the 1990s to now 2017 there has been a reduction, a drop in neonatal deaths from around 5 million in 1990 to 2.5 million today. That means 7,000 babies dying today and every other day of this year. But I would like to draw your attention to the fact that this is something that's largely focused on reductions in South Asia and also East Asia and the Pacific region, but that in a lot of African settings, this is essentially stagnant. So we are not making the progress that we would like to make. And you can ask yourself perhaps why that is, and where the opportunities are to make further progress. And to answer that question, you have to ask yourself, why do newborns die? Why do neonates die worldwide? These are the causes of death in under 5-year-olds, and on the right-hand side, the yellow part of the pie is neonatal deaths. And you can see that there are some causes of deaths that are modifiable, but much more difficult to modify than infection. Largely prematurity and intrapartum related events, but actually about 20 to 25% of neonatal deaths occur due to severe infection or sepsis, basically ending in this common sepsis pathway, and these certainly would be modifiable. So that is one reason why neonatal sepsis is absolutely critical if SDG 3 is to be achieved. Not only is there an impact on mortality, but there's also a substantial impact on morbidity, and this has already been alluded to by the previous speakers. This is a very nice study that looked at the negative effects of neonatal sepsis beyond mortality in sub-Saharan Africa, where they did some modeling, various assumptions about case fatality rate and neurological consequences of sepsis. And I just want to draw your attention to the fact that actually the neurodevelopmental impacts in neonatal sepsis are absolutely huge, which means that we are looking at outcomes that are far, far, far down the line from the actual acute event. And these authors made various assumptions for epidemiological parameters And they estimated the economic value associated with successfully preventing or treating all cases of neonatal sepsis in sub-Saharan Africa over 1 year, that was 2014 as their base case, to be 10 to 470 billion US dollars. It's a very wide range because there's a lot of uncertainty, but perhaps it helps you to know that the GDP of all low-income countries as classified by the World Bank in 2014 was 500 billion US dollars. So you can see that there's really a staggering impact of modifying this particular disease and improving its management, and that's also one of the forces driving GARDP to really invest in this area. Of course, GARDP are not the only and not the first to consider this, and WHO has long recognized neonatal sepsis as a major problem, and in fact provides guidance on its management. Our perspective and GARDP's perspective focuses on the antibiotic management of neonatal sepsis, and the WHO recommendations in their pocketbook for hospital care are that neonates are to be treated with ampicillin and gentamicin, or penicillin and gentamicin as the first-line regimen, with a second-line regimen being a third-generation cephalosporin, so cefotaxime or ceftriaxone. And this is where we really come up against this connection between the world of antibiotics and antimicrobial resistance and the world of sepsis care. Because if we look at what people actually use to treat neonatal sepsis empirically, then unfortunately, at the top you've got the what is being used in countries around the world for neonates, and here for children. You can see that the most commonly used regimen currently in low and middle income countries for neonatal sepsis is meropenem, which is potentially a reflection of observations made by clinicians who are managing these cases about outcomes and resistance. And if we look at the data around resistance, there isn't unfortunately very much, but there's this very nice study from India. These are birth cohort data from India, from 3 centers, where they followed 13,500 babies, and they looked at development of clinical sepsis and then looked at outcomes in this cohort. And you can see that 14% of this birth cohort developed sepsis, which is really a very large number, and quite a few of these were actually culture positive. Obviously, there were also a lot of culture negative cases, and the case fatality rate is absolutely astounding. So it's 26%. Every 4th baby from those babies with sepsis died. And in fact, if they had a positive blood culture, this was every other baby. If they had negative blood culture, still 1 out of 10 babies died. And the fascinating and slightly worrying fact was that the commonest isolated organisms were not organisms that we classically consider to be drivers of neonatal sepsis in our high-income country setting, where we focused on pathogens like group B streptococcus and E. coli that are more manageable in terms of clinically targeting them with antibiotics. But in fact, here we have very difficult to treat pathogens like Acinetobacter and Klebsiella with a high degree of resistance even to the second line regimen. So you can understand that there is a kind of gap opening up between what we are currently still recommending people do and what people actually do. And I think part of the reason is that, in fact, we're no longer looking at community-acquired neonatal sepsis as being the major problem. It is a problem, but actually, these are Swiss data, since we're in Switzerland. You can see that the incidence of sepsis really is highest in the most vulnerable groups, so the very premature babies in the hospital setting. And part of that is something that we have created ourselves, also in lower and middle income countries, because for maternal safety, we have tried to move deliveries into the healthcare facilities to ensure that optimal care is delivered to mums. These are data from various Indian settings, including Cambodia, India, this is Bangladesh, I think, and Pakistan on the right-hand side. And you can see that at least 2/3 of deliveries in these settings are now taking place in healthcare facilities, which is often the right thing in terms of looking after mum. It also means we have a higher survival of premature babies and babies who have complications during delivery, but it also means that newborns are being looked after in neonatal intensive care units in these regions, which are very under-resourced. So this is a neonatal intensive care unit in China. You can imagine trying to prevent transmission of nosocomial infections in this setting is very difficult. This is a neonatal unit in India. Please look at the bottom right-hand corner. You've got 2 babies in a cot. They might be twins, but they might be unrelated. And this is a particularly discussed example from Africa where there were so many births that babies were just being looked after on chairs. And you can imagine that looking after infants with neonatal sepsis in these kinds of settings is a real challenge. This is not to be critical of these settings. They need to somehow accommodate these babies and make sure that they can manage them. But clearly, there are major challenges to address this. And finally, the really important role of GARDP in tackling neonatal sepsis is actually that they are putting it out there. They're actively looking for funding and managing to acquire such funding because unfortunately neonatal infection in particular is extremely underfunded in terms of funding per DALYs compared to some of the other infections, including pneumonia, which is also an area that we're very interested in terms of funding for research. So what are the challenges? So in our case and GARDP's case, so we have this partnership where we're really looking to generate evidence about how best to manage neonatal sepsis, mainly focusing on the context of lower and middle income countries. And it's very, very difficult to study sepsis. This is not something that's specific to neonates necessarily. It's just because it's such a pervasive problem that can be encountered in so many different settings that it's actually quite difficult to design robust research to address this particular problem. And this is something that GARDP is particularly interested in. So you've heard already about target product profiles. This is the approach that GARDP takes, thinking about what is it that would be needed. I draw your attention to the fact that these are all trials that are focusing on empiric management of sepsis, so we are not relying on culture positivity because we know that in a lot of the settings that we're particularly interested in and where we can have the biggest impact, access to microbiology is actually very limited. And you can see also what I said before, that we're looking at a very particular group of pathogens. So with this in mind, GARDP then basically tries to tackle the problem from all different sides, generating observational data to plan these studies, looking at susceptibility in clinical isolates, identifying gaps in manufacture processes and working with pharmaceutical partners to address those, generating various types of in vitro data, and indeed also clinical PK data, which for this particular population is often lacking. And all of these activities are already underway, with some of them actually finished or near finished. So we've defined a number of candidate regimens to improve the management of neonatal sepsis to be used in specific context, and just want again to draw your attention to the fact that we are looking at really old drugs here, where sometimes we have a neonatal indication, sometimes we don't, sometimes we are really lacking the evidence to support dosing. So all of these, although they have been around for a long time, need to be worked up, and some of them are discounted even before they are taken up into further work because there's widespread resistance in isolates that we've collected from these various places where the biggest need has been identified. One of these drugs you can see here is fosfomycin, which is quite an interesting candidate. And just to show you a little bit the approach of GARDP in this setting, GARDP takes a sort of approach where they try to be as efficient as possible in terms of the research to really address the largest number of questions possible, while keeping it manageable, obviously, for the participating families. So this is a fosfomycin trial design where we were looking at PK and safety of fosfomycin in neonatal sepsis, where actually we use randomization, something that isn't usually done in a PK study, to address both the safety aspects. Here, this is mainly about laboratory safety markers, but also the pharmacokinetic sampling aspects to really reduce the number of samples that every baby has to donate in terms of the study, to reduce the burden on families that are participating. And this is completed and is currently in the analysis stages, so we find this to be a very useful model in terms of how we can engage families with neonates who are suffering from sepsis in this type of research in the lower and middle income country setting. And ultimately, this is what we would like to do. And you can see that we're trying to address various questions that are really quite relevant in terms of managing neonatal sepsis, which is what antibiotics should you give and how long should you give it for, particularly if you're working with a population that may never actually have positive cultures, because addressing the microbiological infrastructure may be something that takes more time than we have to really work on reducing neonatal sepsis mortality. And we're really looking at doing this in two groups. So both neonates who would now be treated with penicillin or cephalosporin plus gentamicin, so in a setting where resistance doesn't seem to be a problem or isn't expected to be a problem, where we would like to demonstrate that the candidate regimen is better than what is currently being used, but also doing the same in a group where actually one would already use a much broader spectrum therapy to start with, to address the question whether the new regimen is not worse. So these are the sort of very complex methods that GARDP has taken to try and address the question of neonatal sepsis. And there's a whole host of activities, most of which, so all the dark blue arrows, actually involve neonates or are just focused on neonates. Some of the pediatric work also will involve neonates and is centered really about this issue of the optimal antibiotic management, which currently we don't feel we have a good handle on. So with that, I will end. Thank you very much for listening, and we really hope that we can contribute to ending preventable deaths from neonatal sepsis with GARDP's work.
Thank you very much also for this important talk. Unfortunately, we have taken up the time for discussion, and I discussed with Didier that we have, perhaps we can have some questions on a personal view thereafter. So overall, I'm very pleased to see what has been provided and delivered, and I think we can summarize that we are have been doing and are doing progress, and this is very encouraging for our work in the next years, and I look forward. We should join forces in the future. As I said, I think IPC, sepsis and AMR must come much closer together, join with families and patients and citizens to address these important tasks. And I'm also pleased that we got the gender balance right. Only one old male here and three young women, but I think it's a big goal. We need to work a little bit on diversity, but I think we are going in the right direction. Thank you so much for this session. Good. yeah, yeah, yeah.
So we have to
Certainly.
go somewhere?
Yeah, and yeah, no.